All right, so we're gonna go over the foot and some of the different anatomy and special tests and everything that I think are really important for you guys to understand for this class. And Valerie here is going to be our model, so that way you guys can see what's going on. So the first thing that I need you guys to understand is the arches. And as we talk about the arches, there's going to be 4 that you're gonna have on the plantar aspect of their feet. And so longitudinal, right? That means long. And if you look at the outside, this is lateral. So her lateral longitudinal arch is here, her medial longitudinal arch is here. And when people think about their arch, they really think about that medial longitudinal arch as being their arch. Then we have 2 other arches that go the opposite way, they go crosswise. And when we think about those, we have the transverse and the metatarsal arch. The metatarsal arch goes across your metatarsal head, so kind of like where the ball of your foot is. And then the transverse arch goes more through, again, where people think that their arch technically is. These are all really important arches in the structure and function of your feet, and you really need them to be intact in order to have like that regular kind of spring load thing that's gonna help propel you when you're walking and everything else. But you need to know that there are 4 arches in your feet and that they all need to be intact as we're going through those kinds of things. So from an anatomy side of what's going on, and I'm not going to hit everything because it's all kind of in your book, and you can look at the bones. She obviously doesn't have bones showing, so that's a little bit harder, but just know that when we talk about things in our hands and in our feet, the great toe and the thumb is always 1, so 1, 2, 3, 4, 5, and the toes are phalanges, and we have distal, intermediate, and proximal phalanges. The great toe and the thumb only have a proximal and a distal. Proximal always means closer to the heart or closer to the core, and then distal always means further away, but we only have 2, right? You know that you only have 2 bones here. The same thing is in your great toe, but the other toes all have, 3. And so they also have an intermediate bone in there. So they have a proximal and intermediate or a middle and a distal phalange. And then understanding the joints, the distal interphalangeal joint and the proximal interphalangeal joint. From there, if you become a little bit more proximal, we have the metatarsals. So the metatarsals are these long bones in your feet. And again, we talk about them in the same numerical system. So the one that's most medial is 1, then 2, 3, 4, and 5. And they all line up perfectly with your toes, okay? And in that, what you're gonna see, so that ball of your foot, you have 2 bones in here, and they're called sesamoids. And the point of these sesamoids is to help with these long tendons that are coming up to your great toe, so that way they can help with propulsion. Hopefully everybody knows that your great toe is crazy important for gait, but also for balance. If you don't have your great toe, your balance is terrible, because this guy and all the muscles that go to it really contribute to your ability to balance and stand and walk and everything else. But these guys right here really help decrease the amount of force or muscle that's necessary to make that stuff happen. So these 2 guys are really important, and when we talk about sesamoiditis or sesamoid fractures, we're talking about one or both of these. And the thing that you need to know about sesamoids is these bones aren't like the rest of the bones. They don't actually articulate, so not end on end with other bones. They're actually encapsulated by tendons. And so they're literally there. Think about, like, if you go to a well, is it easier to just throw a rope over the well and pull it up full of water, or is it easier to use a pulley system? Definitely a pulley system. That is the point of sesamoids. Sesamoids help decrease the amount of effort that you need to propel yourself forward. So they're really, really important, and we very much want to keep them in there, okay? Then from there, we come up to all the crazy looking odd shaped bones that are in your hind foot. And these are all called tarsal bones. And so when we think about these, we have our metatarsals here, the nice long bones, and then we have our tarsals, and this heel bone is called your calcaneus. And this is an important area for lots of injuries. We can get stone or heel contusions here, but right on the anterior aspect of that is right where your plantar fascia is going to start, and then extends out, and it comes all the way to these met heads. So if people have ever had plantar fasciitis, that kind of fascia comes all the way up. So if you ever have somebody that's complaining of pain right here, and then especially like first thing in the morning or something, we're really talking about this plantar fascial aspect that's kind of going on. For some of the other muscles, the things that I want you to think about, and we're going to talk about motion first. When we talk about the toes, if we curl our toes all the way down, that is called toe flexion. And then when we bring them all the way up in the air, just like that, that is called toe extension. And then if you spread your toes all the way out, which is much harder to do, hopefully everybody can see, look how nice she's doing, that is called toe abduction. And that's kind of, and I guess if you squeeze them together, that's toe adduction, but it's kind of really hard to do that, but she's doing great. And you can kind of move them individually, like you should maybe be able to move your toe, your great toe a little bit individually, because your great toe has individual muscles that do flexion and extension. The other toes are kind of linked in all together. So when we talk about flexion, if we're pulling them down, that means that all of our flexors have to be on the plantar aspect of our foot. And if extension is pulling them up towards the sky, then that means all of our extensors have to be on the dorsal side of our foot. So that means that all of our toe extensor muscles are all on the anterior aspect of either our foot, ankle, or lower leg, and all of our flexor muscles are all on the plantar aspect or on the posterior aspect of our lower leg. And so those are really important things, because when you guys are trying to learn the muscle anatomy, if you think about the directions of things and you understand that, that's going to make everything so much easier as you're trying to learn anatomy placement, okay? What else? The other thing, is intrinsic and extrinsic muscles. So intrinsic muscles are muscles that start within your foot and end in your foot. So they don't cross your ankle joint or anything else. They're just only right here. And then the extrinsic muscles all start somewhere up here, and then they cross into your foot. So if you bring your foot down, you should be able to feel that Achilles tendon get real tight. That is an extrinsic muscle. It's your gastroc and your soleus that are getting tight back there that are making that happen. But you do have some smaller muscles in the bottom part of your foot that help move your toes and help contract your arch. And then you also have some smaller muscles on the dorsal side of your foot that do the same thing for your toes, okay? So understanding those, I think, are really important, the intrinsic and the extrinsic, and understanding flexion and extension. A couple other directions that I think are really good. The other thing to talk about is like your gastroc, so the thing that makes like the heart-shaped thing on your leg. That's your gastrocnemius, and then underneath that right here is going to be your soleus. Those two come together to form your Achilles tendon. And the word that we use for that is called your triceps surae, S-U-R-A-E, and it's because there's two heads on your gastroc, your medial and your lateral, and then your soleus only has one, so that's three total heads. So triceps surae. And surae just kind of means like a conjoined tendon that brings it all the way together. And then just so you know, that runs all the way down. So it comes all the way down and it inserts on your calcaneus, but that fascia also continues around and goes underneath your foot to become part of your plantar fascia. So you can actually have a tight gastroc and make it give you plantar fasciitis, which kind of sucks, but it's not weird to happen at all, okay? What else? Okay, when we're talking about the stuff on our foot, remember I said for the metatarsals, the first one right here is our first. Then we line it up with the second toe, so that's our second metatarsal. Third, fourth, fifth. Our second and third metatarsals are the most common. We're going to talk about those in a little bit for stress fractures in the foot, so just keep that in mind. Sorry, I'm kind of bouncing around, I don't mean to. But I also want to talk about the rest of the joints. So remember I said your toes are called your phalanges, and this long skinny part of your foot is called your metatarsals. So the joint in between them, and this is why it's so important to learn the bones. Most joints are named for the two bones that are on either side. So when we talk about this, we call it the MTP joint, or the metatarsal phalangeal joint, okay? And the joint is where they separate. So the balls of your foot, those are still your metatarsals. It's the space between the most proximal phalange and that metatarsal as we're doing that kind of stuff, okay? And then if you come up a little bit, you should probably be able to feel a ridge in that dorsal part of the foot. And that ridge is right at the very end, or the base of your metatarsals, and where they meet with your tarsals. And that is called your tarsal metatarsal joint. Remember I said all these weird back heel bones are called your tarsals, and these are all your metatarsals. So again, they're named exactly for what the group of them are named. So that is something else to remember and how they line up that way. So the whole entire thing is called the tarsal metatarsal joint. Okay? All right. So from there, for toe motions, I already talked to you about toe motions. And for ankle motions, these are foot and ankle motions. The things to know, I think, that people get the most confused with are pronation and supination. And we'll talk about them again in the upper extremities, so it's similar but not quite the same. With pronation, if we have somebody kind of in a neutral foot and they're in a pronated position, what you're gonna see is they're gonna kind of walk on the inside part of their foot, and oftentimes they're gonna have something called pes planus, which means that they have a very flat, I call it like a Fred Flintstone foot. And then if they have a more supinated foot, meaning that they walk on the outside part of their foot, we often see those people have something called pes cavus, which means that they're arched. They have a really, really high arch. I don't know if you can kind of see her. She has like a kind of normal, almost high arch. And with these people, they tend to walk on the outside of their foot. And when we get higher up the chain, we'll talk about how that also affects our knee and our hips as well, because they all kind of, just one great big long kinetic chain, and they all go together. With ankle motions, and we have to talk about those because they pertain to the foot, these are also important for you guys to understand. So when we're talking about it, if I say dorsiflexion, remember I called this the dorsal surface of your foot. So if you're going to dorsiflex your foot, you need to move this part. So you're going to pull it all the way up in the air, like bringing it towards the ceiling or bringing it towards your face. And then when you do plantar, remember I said that this bottom part is called your plantar surface. You're gonna plant it down into the ground. Like think about mashing a gas pedal or something, or a brake pedal might be better. And so you're gonna point those toes and you're gonna push it all the way straight into the ground. And let me kind of do it sideways a little bit so you can see dorsiflexion is bringing it all the way up really high, and plantar flexion is bringing it all the way down into a really nice point, okay? Then the other directions that we have are going to be inversion and eversion, not to be confused with pronation and supination. So when we're going to invert our foot, we're going to bring it to the inside. And think about when we invert that, a lot of times if people sprain their ankle, they kind of have that go on, right? So what we see is we have straight, okay, let me clear up a little bit. So we have abduction and adduction. Coming to the inside is adduction, which is, think about adding to the middle, adduction, and abduction is going away from the midline. And then when we have inversion, it's going to be a mix of supination, plantar flexion usually, and adduction. And when we do eversion, it's going to be a mix of abduction, dorsiflexion, and what was my other one that I just missed? Oh, pronation. Yeah, I knew that there was another one. So this is going to be when we evert our foot. This does not happen very often. Eversion is not a motion that we go through very much. Inversion is. And when we talk about the bony anatomy, there's a reason for that. Out here, your outside ankle bone is part of your fibula. Your fibula is that skinny long bone that runs down the outside part of your foot, and this is called your lateral malleolus down here. Then you also on the inside part have an inside ankle bone called your medial malleolus. Well, your lateral malleolus hangs much lower than your medial malleolus, so it serves as a bony blockade that prevents you from coming out. Also, you have some ligaments that we're going to talk about in the next chapter out here that are not nearly as strong as what we see this ligament in here. It's called your deltoid ligament. It's called deltoid for 3, but technically there's 4 ligaments in it. And it's really strong, and that also prevents us from going into eversion. And so the most common mechanism for ankle injuries really as a whole is inversion. And again, that was a mix of adduction, supination, and plantar flexion. So this is our most common kind of injury or mechanism that we're going to see things happen. So make sure you understand dorsiflexion, plantar flexion, adduction, supination, and pronation. Remember, supination's on the outside of your foot, pronation's on the inside of your foot, and then inversion and eversion. All right. Pulses. So we have a couple places where we can check pulses in the foot. The easiest one is really our dorsal pedal pulse. So basically what you're gonna do is you're gonna come kind of into the crevice of their ankle, about where you can see like that fold. And on the very top of your foot, really lightly put your fingers right there, and you should be able to feel a nice pulse. It might not be crazy strong, and if you push too hard, you're definitely gonna crush it. The other one is just posterior. So remember, posterior means behind. Posterior to your medial malleolus. So see my fingers back here? I'm just right behind her medial malleolus, and this is another great assessment place to be able to get a pulse. And then don't forget, we talked about PMS before, so we can always do a quick pulse assessment by doing our cap refill on the toes or any place else in her foot as well, okay? All right, so for movement, when we do stuff, we already talked about ROM. Everybody should hopefully know ROM. That means that she does it all of herself. And then we have PROM, which means I move it for her. So we always have them do ROM first, and then I do PROM, because if she can't move it, I don't want to force her into a position that might be really painful for her. And then resisted range of motion, remember, is break test. So I would say push, and she wouldn't move, and then I would push her to another and say push, and then I would say push. But again, they're not moving. They're the isometric kind of contractions as we do this. The next couple tests that we have are tests that we would use for either nerve or for fractures. And so when we do these tests, for fracture tests, the things that we would look at are going to be Morton's test, also known as the squeeze or compression test. We also have Tinel Sign to do this kind of stuff. So if I think that I have a foot fracture, number one, I'm not going to do a whole bunch of crazy stuff, but stress fractures can be a lot harder to figure out. So what we would do is, if I think that she has, so stress fractures most commonly happen in the second and the third metatarsals. You need to know that, second and third metatarsals. And one of the things that I would do, the first one, super easy, is just the tap test or the flick test. And all you do is you just flick their toes. Now, the thing that I need you guys to remember when we're doing special tests is, if I thought this foot was messed up, I would do it on this foot first. Always do everything bilaterally, which means both sides. And you always do it on the good side, and then you do it on the bad side, because you need to see what's normal for them before you see what hurts, okay? So I can start with my tap test or flick test and see if she reports like radiating or sharp pain in her foot. And if that's negative, I can do the squeeze test, which is also called the Morton's test. And what you do is you take your hand, or sometimes two hands depending upon the size of their foot, and what you're going to do is you're going to grab around the long part of their foot, and you are going to squeeze it together, like squish it like that. And if they have a stress fracture in there, they are not going to like that at all, because it's going to make that one spot where they're having pain really, really hurt bad, and they're going to tell you to stop or kick you or hit you with their arm or something. They can also have something called a Morton's neuroma. The Morton's neuroma, so again, as we count, 5, 4, 3, 2, 1, what you can have happen is have a ganglion cyst, meaning like a nerve bundle that gets caught. And typically we see it happen between the third and fourth metatarsal heads, so these dudes all the way up here, and they get stuck, and they're gonna complain of like radiating, burning, numb pain, something like that, that comes into these two toes. So you would do the exact same test, squeeze test, also called Morton's test. And again, you would squeeze, but focus on squeezing the met head, so the very distal part of their foot together. And by doing that, what you're doing is you're squishing those bones together, so it would squish that nerve, and then it would cause that same symptoms like the radiating pain or numbness or whatever to go on. And again, they're not gonna like it. So if it's positive for pain in the bones, then it's a positive fracture test. If it's positive for neurological symptoms, then it's a positive Morton's test. But it's really basically the same test. It just kind of matters where you put your hands and where you're focusing on that kind of stuff, okay? For myotomes and dermatomes, I just need you guys to know that they exist. Myotomes, again, are testing muscle, and dermatomes are assessing sensory stuff. So touching in very specific places to know where they are, and we can go over that stuff a little later. And then with Tinel Sign is gonna help us assess for neurological problems. And ideally, we don't have a ton of neurological problems going on, but we do have a nerve, same place as the posterior tibial artery, how it ran posterior to that medial malleolus. We also have a nerve that runs there, and so Tinel Sign, and we're going to use the same test all over the body. So you need to get to know the name Tinel Sign. But what you're gonna do is you're just gonna take your 2 fingers. You don't have to use some kind of crazy special tool. And they would tell you, hey, I have like this weird nerve burning, shooting, something kind of pain going on. And you'd say, okay. And so you would find that nerve and then you would tap it. And if they say that that reproduces their symptoms going down into their foot, then that's a positive test. So any test that reproduces the same symptoms that they've been complaining of, whether it's pain, burning, numbness, aching, whatever, that's a positive test, okay? And then for other special tests that we can do in the foot, I mean, those are kind of the big ones, I would say. Well, I'll talk about some as we get really specific to them. But when we talk about palpation, the thing that I need you guys to know is if it's supposed to be soft, it should be soft. If it's supposed to be hard, it should be hard. We've learned crepitus before. Crepitus is that grinding thing, and either they can feel it, or we can hear it, or sometimes we can feel it. So if you do like that compression test and you can feel grinding in their foot, that's not a stress fracture. That's a full-fledged fracture, and that's a bad thing. We don't want that stuff going on. And so make sure that you're touching things to make sure what's going on. Don't touch straight on the spot that they're complaining of. You want to touch in a further away spot and then work up to it. And remember, you always go to the non-involved side first and then come to the involved side. So kind of take your time getting there, but make sure that you're assessing all the different areas and in spots of their feet and stuff that can be in there. For fractures, I'm going to go over kind of where the structures are so that you guys understand, and then talk about kind of all the tidbits about the injuries in a different narrated. But again, the talus, so if you guys can find where your ankle is, like where that division is, so if the person's really relaxed or you're really relaxed, you should be able to feel kind of like a crevice right underneath there. Your talus is this very top part of your foot, and this very top part that meets with your tibia is called your talar dome. And sometimes you can get fractures up in here. I've seen them before where they happened with really bad ankle sprains. We often see them with ankle dislocations because bad stuff happens. I actually had a baseball player not hear field or warning track, and he got his foot jammed up into the back fence in really high dorsiflexion and inversion. And I call it, so remember we talked about comminuted fractures mean that bones are broken into 3 or more pieces. He like starry nighted his talus. It really wasn't there after that. Like it looked more like sawdust in the MRI. It was really bad. And I have videos of being in the ER of them like thinking that his ankle was dislocated, so they kept trying to put it back in. And they couldn't put it back in because he actually didn't really have a bone left there. And so he had to fly to a specialist and have them reconstruct a talus for him so he could actually like use his ankle again. It was not fun. The calcaneus is your heel bone, and it's the biggest bone of your foot. It's great big, and we can have all kinds of problems with this. If you land, I've had people that I've known, friends and athletes, who have jumped off things kind of high and broken their calcaneus, and these can take quite a bit of time. And again, we can also get stone bruises and stuff, so wearing good shoes, not jumping off roofs, barefoot, stuff like that, that's a good idea to avoid, okay? Heel contusions often get confused with plantar fasciitis because heel contusions are going to start here on the calcaneus. And remember I said plantar fasciitis usually starts here, right where you can feel that tight part. So if I take Valerie's foot all the way back and you can feel this really tight band, and it comes all the way down right to this anterior part of her calcaneus, that's her plantar fasciitis. Well, sometimes people can get bruises really close to there, but usually the bruises are actually on the heel, not on this plantar fascial part. The difference is going to be the heel is going to have a one-time mechanism, right? You're going to hit your heel and now you're going to have a bruise. That's how bruises work. That's how I got that bruise, I think. I don't really know how I got that bruise. Plantar fasciitis is going to be a chronic thing where it's going to go on and on and on. A contusion is going to hurt every time you push it. Plantar fasciitis really hurts most, like in first steps in the morning or after you've been sitting for a long time, and really when you dorsiflex your foot and really like pull your toes all the way back, any kind of this motion is really going to hurt it. This isn't going to hurt contusions really as much. So understanding the difference in location and the signs and symptoms and the mechanisms are really going to help you guys isolate some of this stuff down and figuring out what's wrong with people. Another thing with Morton's toe, which she does not have, is that people, sometimes people's first toe is shorter than their second toe. And so people think that it's actually the toe, but it's not the toe at all. It is their metatarsal. So their first metatarsal is actually abnormally short. And so what happens is this toe now is shorter than the second toe. And so that means that your second toe has to take on a lot more of the effort for push off when you're walking and running and jumping. So people tend to get a lot more stress fractures and have a lot more problems with their feet when that happens. And that's a genetic thing. You're born that way usually. It's not like it just happened. But that's something to pay attention to. So it's actually not a toe problem. It's a first metatarsal problem. So make sure that you guys understand those differences. I already kind of talked about plantar fasciitis, so make sure you understand those. And now we have a special injury called a Jones fracture. Mechanism is very similar to ankle sprains. Typically we see that inversion plantar flexion kind of thing. And so all of your ankle ligaments are up here around that lateral malleolus, but instead what you're gonna see is these people are going to complain of pain on this very lateral aspect of their foot. And typically, if you follow it down, if you feel on your foot, you can feel like this very edge part of your bone, it kind of sticks out a little bit. That right there, see, I'm not next to her ankle at all. Her ankle's way up here. See where this is? I'm way down here. This is where a Jones fracture happens, right here. And they're gonna have pain and swelling, and they're gonna complain usually of a pop or some kind of snapping that happened right here. The swelling is not gonna be in their ankle, not up here. I mean, maybe they sprained their ankle too, so technically speaking, I guess they could, but it's gonna hurt here. So you guys need to know a Jones fracture happens in the metatarsals, specifically in the very either neck or base of the fifth metatarsal. And this is really difficult to heal because you have a muscle that comes down, your fibularis brevis, some people call your peroneus brevis or perineal brevis. It inserts right at the tip of that. And so every time you use your lower leg and your ankle, it's gonna pull on that. So it's really, really hard for that particular fracture to heal. So people usually have to be casted or in boots for a really long time, or for athletes, we often take them to surgery because we want them up and back faster, and we also want it to heal. And just being in a cast, it's not a guarantee that it's actually gonna heal, but it's important to know where these two spots are. They're not the same. All of your ankle ligaments are up here around your lateral malleolus. Jones fracture, way down here on your foot. Similar mechanisms, not the same injury, guys, okay? Already talked about metatarsal stress fractures. Hopefully everybody's heard me now. Second and third happen from all kinds of things. And again, there's a difference between a fracture and a stress fracture. A fracture, one-time thing, I broke it, right? One kind of mechanism and now it's jacked up. For a stress fracture, it's usually I've been changing my surface or I really increased what I've been doing. And it kind of was annoying in the beginning and now it's getting worse and worse and worse. So you need to also really, again, when we're talking about this stuff, really think about the mechanisms. Is it an acute thing? Is it chronic? And that's gonna tell you a lot about what kind of injury you should be suspecting. Same thing for both the Jones fracture and the stress fractures. Doing that compression test or squeeze test and also doing the tap test, they're all gonna hurt. They're not gonna like them. For a fracture, for a Jones fracture or metatarsal, like regular fracture, for a Jones fracture specifically, and then also for stress fractures, you can use all of those fracture tests for all of them, and they should be positive. For the sesamoiditis, remember I said that those are right here on the bottom and how they run through those tendons right there, your flexor tendons for your hallucis. By the way, if I ever say hallucis, that is the fancy word for great toe. And you're gonna see a lot of the muscles are named hallucis. So if you see hallucis in the name of it, it's going to your great toe, okay? Okay. And again, that is going to be an important thing for us. And it's often a chronic thing, but we can also get sesamoid fractures as well. And again, it's from landing on them. Already talked about the Morton's neuroma and how we use that squeeze test or Morton's test to try to get those to come through. And then great toe hyperextension, also known as turf toe. So I want to make sure that I explain this. So normally, it doesn't have to happen on turf, but it way more frequently happens on turf. And what happens is, let's go that way. Normally you're running, and oftentimes, you know, your toes kind of come back into full extension as you're doing stuff anyway. Like if you're in a starting block position, or you're getting ready to like come out of the blocks, or you're getting ready to come off the line or something, you're gonna kind of be in extension. But what happens is your great toe kind of gets stuck in the ground and it gets pushed way, way back, like way more back than it's supposed to get pushed. And so what happens is you actually can tear these medial ligaments as well as the muscle, so these flexors on the hallucis side, so on the bottom side, and it makes it so painful to have your toe come back. And so often what we'll do is we'll tape the toe and then pull it down, and we'll pull it into a flexed position a little bit. And the reason why we pull it into a flexed position, so I don't know if you guys can see, this is neutral, so flexed. I pull it down here because her body weight is gonna be way greater than the strength of the tape. So when she stands up on it, it's gonna let it go into neutral a little bit, and then if she gets into that plantar flex position again, it's gonna maybe let it come a little bit past neutral, but it's not gonna let it come all the way back again. So we're gonna be able to protect it a lot more. The other option that I actually really like a lot is there's metal inserts that you can put into people's shoes, and they still allow some flexion, but you have to order them specific to their shoe size and shoe style, because some are really wide and some are long and some are whatever, and they're steel, they're metal. You can't cut through them once you get them, so you gotta order the right size when you do it. You can't just order whatever and see what happens. But they work really well, and they really allow people to come back and be able to participate and to do what they wanna do much faster than if you hadn't done that stuff at all. So hopefully this really helps explain some of the special tests and some of the differences between the injuries, and I'll try to hit up the Russet stuff in another lecture. Thanks.